Hello and welcome everyone to another Team FRCR 2B session, which is today conducted by our very own Dr. Palwasha. Dr. Palwasha has been a member and is a member of our group, and she cleared her March 2B exams. She did her residency from Bolan Medical Complex Hospital and her fellowship from Shaukat Khanum Memorial Cancer Hospital, and is now working in her parents' institute of Bolan Medical Complex. We are really honored and happy that Dr. Palwasha has given us her time for this session, and I hope all of you would find it useful. Thank you so much, Dr. Palwasha. Over to you.
Thank you, Sabahat. So nice of you. So hello, everyone. Sabahat has given a really good introduction. So I will just quickly jump to the cases. So I'm going to discuss 20 cases. Will take around about 70 to 75 minutes. And I will just be discussing some important clinical and reporting tips, okay? So we move to the first case. This was a 40 years old male who came with a growth in the premaxillary soft tissues, and a CT scan was performed. This was excellent images of the contrast enhanced CT scan, and here we can see that there is enhancing soft tissue lesion, which is sitting in the premaxillary soft tissues or the malar soft tissues. This is causing some erosion and thinning of the adjacent bone, and this was showing some superficial ulceration as well. On the subsequent images, we saw a necrotic lymph node, which was sitting in the right submandibular region. And once you see, a cutaneous lesion in the head and neck, of course, it would be difficult just based on the imaging to say if it's a squamous cell CA or a basal cell CA. But if you see a necrotic lymph node, then you would have some, idea that you are dealing with squamous cell CA, okay? Because squamous cell CA are notorious for causing necrotic nodes in the neck region, okay? And once you know that you are dealing with squamous cell CA, then specifically you have to look at the lungs for cavitating metastasis, okay? So this was actually a biopsy-proven squamous cell CA. So from exam point of view, just see the necrotic lymph nodes, cutaneous lesion, and then tell your examiner that you are specifically looking for cavitating metastasis in the lungs. The examiner might ask you, if you would put a needle in this lymph node, ultrasound guided FNA, or let's say ultrasound guided biopsy of this lymph node, would you do that? So the question to that answer would be no, because we don't do biopsies of the necrotic lymph nodes, because those are mostly inconclusive. So you would put a needle, you would intervene, patient would spend money doing a histopath, but that would be inconclusive, and you know that already. So tell your clinician there's no point in putting a needle in a necrotic lymph node. Rather, it's better to do a biopsy or tissue diagnosis of the lesion, which is there in the malar soft tissues, okay? Another thing that I wanted to point out, when I was in my residency and I used to read Sutton, I always used to read adenoid cystic carcinoma in the head and neck region, which was, notorious for causing perineural invasion, perineural spread. And then I always used to think, this perineural spread is seen in adenoid cystic carcinoma, but remember, a squamous cell carcinoma of the head and neck region, basal cell CA, mucoepidermoid carcinoma, adenoid cystic carcinoma, these are all, the causes of perineural invasion. And in this particular case, it is very much important to tell the infraorbital foramen through which the infraorbital neurovascular bundle is going to pass. That is something very important that you are going to tell your head and neck surgeon. So this was actually in close proximity to the infraorbital foramen, and most of us would not report this, not knowing the fact that the squamous cell carcinoma can also show perineural spread. One more thing that I want to stress upon is that there's a difference in the perineural spread and a perineural invasion. Perineural invasion is something or a term that would be used by a histopathologist, and perineural spread is the terminology that would be used by the radiologist, okay? So we move to the next case. Case number 2, a diabetic female patient around 60 to 65 years old. I know many of you would see this and you would say, this is emphysematous pyelonephritis. So what's special about this, okay? I know this is emphysematous pyelonephritis. So this was actually, contrast enhanced CT scan. Of course, we can see a lot of air, which is there, replacing the renal parenchyma as well as in the collecting system. There was air in the wall of urinary bladder, so emphysematous, pyelonephritis with emphysematous cystitis. But I wanted to show this case for the fact that in this case shows the delineation of the retroperitoneal anatomy very well. Okay, so in this particular case, can you see these specks of hair, which are just sitting interior to the aorta and to the inferior vena cava? So the perirenal space is connected to the contralateral side, just interior to the aorta and the inferior vena cava, and that's why we can see air interior to the aorta and inferior vena cava. And we can also see some amount of the free air, which is sitting in the right perinephric space as well. And this has gone across the midline to the right side. And over here, we can also see some amount of the air in the peritoneum. So which basically means that the retroperitoneum is connected to the peritoneum as well. And it is actually the interior perinephric space connecting the retroperitoneum to the peritoneal area, okay? Now, in the next image, I've just shown you the lung window, showing you the similar findings, of extension of free air to the contralateral side, to the peritoneum. And the free air was also going, to the retrohepatic area and trying to go to the bare area of the liver. So again, the perinephric area, the interior perinephric area would be connected to the bare area of the liver as well. And again, you can see some amount of air in the mediastinum. So retroperitoneum is connected to the mediastinum as well. So this was, a simple case of emphysematous pyelonephritis, emphysematous cystitis, amount of air in the urine, in the ureter as well. But I just wanted to show that it was so huge that it was going all the way here and there, and it was delineating the anatomy and the extension of the retroperitoneal space. Again, we can see, free air along the hepatic margin in the mediastinum. So then I searched up, and there were a few case reports which were saying that emphysematous pyelonephritis can present as pneumomediastinum, as a pneumoperitoneum, etc., etc. Okay, so this was, a simple case, but some atypical presentation due to extension of the free air to the different areas. Okay, and case number 3 was again, an interesting case. This was a patient who came from Afghanistan, and he initially presented to the pulmonologist, and pulmonologist advised a CT pulmonary angiogram. Now, in this case, we can see that the right-sided chambers are dilated, and then we can see there are filling defects within the pulmonary vessels. These all are actually the filling defects on right side as well. These were actually, when I checked, these were actually non-enhancing fluid attenuation areas. And again, we can see it on left side going to the left upper lobar artery. Then on coronal reconstructed images, again, we can see multiple filling defects, hypodens, fluid attenuation areas. The upper abdomen, which is covered on the pulmonary angiogram, shows, non-enhancing, hypodens area, which is going all along the middle hepatic vein to the inferior vena cava. This also showed some peripheral calcification. On axial images, we saw that there was a cyst sitting in the left hepatic lobe with specks of calcification in the periphery, and some cystic areas with partial calcification in the posterior segment, right hepatic lobe. And we saw that these were going all the way to the inferior vena cava, and hence to the right heart chambers, and hence to the pulmonary vessels. So it was actually a case of hydatid pulmonary embolism. In my residency, I used to memorize the Chapman, which said that there could be fat embolism, there could be talc embolism, there could be tumor embolism. But then with time, I saw all the cases of pulmonary embolism secondary to DVT. And I almost forgot, that differential. But then when I saw this case, this was, a hydatid cyst going to the hepatic vein, to the inferior vena cava, showering the pulmonary vessels and causing hydatid pulmonary embolism. Okay, so this was again something, common. Most of us, we see hepatic hydatid cyst, we commonly report it, but this was with some atypical presentation. And then I searched up the text again, and there was some case report of massive pulmonary embolism due to hydatid vesicles. Case number this is actually not my case. I've taken the image from internet, but many of you would see that this is an acute subdural hematoma. What's so special about it? This of course is an acute subdural hematoma, and this is causing a lot of midline shift. Okay, so in this case, what I wanted to tell you, when you're studying for exam, things are very typical, because you would be studying what's the difference between subdural hematoma, what's the difference between extradural hematoma, what are the causes, etc., etc. But once you're done with your exam, or once you step into your clinical practice, then you have to become a clinical radiologist. Okay, so in this subdural hematoma, what I wanted to tell you was that first thing is that there's a difference of evacuation of these hematomas. The acute subdural hematoma, if it is causing mass effect, would require a craniotomy, okay? And an epidural hematoma would require a burr hole, okay? One is that difference, okay? And then the next thing you must see is if the resultant subcalcine herniation is in proportion to the extent of the hematoma on imaging, okay? And how are you going to decide if, let's say, you're going to take the thickness of this subdural hematoma and you're going to measure the amount of the midline shift towards the contralateral side? If these two are corresponding to one another, then you're going to think that, okay, the midline shift is basically because of the subdural hematoma, okay? But let's say there's a difference of 3 millimeters between the amount of the midline shift and the thickness of the subdural hematoma. Then you have to think, of some adjacent cerebral edema, which could be there with subdural hematoma. And in that particular case, if the difference between the thickness of the subdural hematoma and the midline shift is more than 3 millimeters, you just have to call your neuro colleague and you just have to tell them, see, I think that there is disproportionate amount of the midline shift, and I see, or maybe I feel that there is a cerebral edema, and in that particular case, they need to aggressively treat the cerebral edema in that particular case, okay? Because let's say if the neurosurgeon thinks that all amount of the midline shift is because of the subdural hematoma, and he does not think about the cerebral edema, and let's imagine he does a craniotomy, okay? So the brain under pressure due to subdural hematoma as well as the edema is going to come out, because it's trying to come out, is trying to create a space for itself. So there is going to be a large, extracranial herniation in patient. And even the neurosurgeon would be thinking, what went wrong? I wanted to decompress the brain, but I don't know what went wrong. So what went wrong is actually this difference of 3 millimeters, which is between the thickness of the subdural hematoma and the amount of the midline shift, which you need to report, and you need to call your neurosurgeon and you tell him, see, I feel there's disproportionate amount of the midline shift. I feel there's cerebral edema. You need to do something about cerebral edema before you put your hands into subdural hematoma, okay? Case number 5 is, again, many of you, this was 40 years old male with a swelling in the Inguinal-scrotal region, I don't know, for the last 2, 3, or maybe 4 years. And so he came for CT scan. So many of you, I know that you would just see and you would say, oh, it's a huge mass and it is showing fat density as well as soft tissue density. So it's a liposarcoma. Of course, this was a liposarcoma, but I showed you this case because, a typical lesion in a slightly atypical location, usually we get to see retroperitoneal liposarcomas, but this was an inguinal-scrotal liposarcoma, okay, this huge one. And on imaging, it's important to differentiate between the retroperitoneal liposarcoma, which is going to the inguinal region, and the inguinal-scrotal liposarcoma, because the surgeon is gonna take it out, and the approach, surgical approach, of course, would be different. And a retroperitoneal liposarcoma, which is large enough and going to the inguinal region, would be associated with more morbidity and mortality compared to the inguinal-scrotal liposarcoma alone. Okay, so you need to differentiate the location if it is retroperitoneal going to the inguinal region, or if this is Inguinal-scrotal, because for a surgeon, it is very much important information that you are going to provide, okay? So a typical appearance, but slightly in an atypical location, okay? Case number 6, this was a young girl, around 23 years old, and she came with a mass in the pelvis, and she underwent an ultrasound, and over there she was reported as a huge, subdural fibroid, and she came for CT scan. So when you see, such kind of solid lesion, in a female pelvis who is, young, maybe 18 years old, 20, 23 years old, the first thing should come into your mind, if this is a subdural fibroid, and in that particular case, you need to differentiate if this is originating from the uterus or not. So this was clearly not originating from the uterus, okay? This was not originating. Here we can see the uterus separately. And if it is not originating from the uterus, then it's not fibroid, okay? And then what's the next possibility? The next possibility is it's originating from the ovary, okay? So this was an ovarian lesion, and this was originating from the right side with a prominent vascular pedicle, and it was solid, showing heterogeneous enhancement. And this was actually an ovarian dysgerminoma. So I want to tell you that if you see few cases of dysgerminoma, if you're able to, differentiate it from the fibroid, and these lesions usually are showing a prominent vascular pedicle, and mostly these are right-sided. So a young female, large, solid mass with a prominent vascular pedicle, you do not need to wait for histopath. Okay, you can just simply say that you are dealing with a dysgerminoma. And when it comes to dysgerminoma, okay, the usual tumor markers, let's say CA-125 levels, would not be beneficial because those are elevated in surface epithelial tumors, okay? In dysgerminoma, the tumor markers could be beta-HCG and LDH. So that is how you're gonna see if you're dealing with dysgerminoma or not, okay? So you're gonna see beta-HCG, LDH, and not CA-125 levels, and young female, solid mass in the adnexa. Think about dysgerminoma, okay? Case number 7, again, a young female, who thought she's pregnant. She went to gynae. The gynae people sent her to us. So we said that it's a mass, do a CT scan, and this was again a huge dysgerminoma, separate from the uterus, originating from the adnexa with linear, curvilinear calcification and a central necrotic area. So this again was germinoma. So I just wanted to give you a concept that you can, very confidently say that this is a dysgerminoma once you know that the demographics of the patient, once you know this is not fibroid, once you know that CA-125 levels are within normal limits, you can very easily say that this is dysgerminoma, okay? Case number 8 was an unfortunate male patient who was referred from periphery to our hospital after a gunshot wound. He was immediately operated because he was in a bad state, but despite surgery, he was in a state of shock, and so he underwent a CT scan. This is a post-trauma patient, post-trauma CT scan. On plain CT scan, you can see heterogeneity of the liver with hyperdense areas. There is hemoperitoneum. There was ear and a peritoneal drain from previous surgery. And on axial images of the arterial phase, of course, we see lacerations, we see contusions, which would be better seen on portal venous phase. But this was, this area was alarming, and this was an area of contrast blush, okay? Now, keep one thing about contrast blush in your mind, what the radiopedia says. Radiopedia says, contrast blush basically means 2 things. 1, you are dealing with active contrast exposition, okay? Or you are dealing with a post-traumatic pseudoaneurysm. So how you are going to differentiate, of course, you're going to see it on the delayed imaging. If the density of the contrast is increasing, then you are dealing with contrast extravasation. If the density reduces on subsequent delayed images, you are dealing with a pseudoaneurysm. So interesting in this patient was that this was actually a contrast extravasation, but it was actually from the replaced right hepatic artery. So there was an anatomical variant as well. Then there were hyper-enhancing adrenals, and there was hyper-enhancement of the bowel wall, and kidneys. We were just looking at the kidneys. We were thinking if this is a laceration, if this is a contusion. It was actually giving us striated appearance, and then we thought of tubular necrosis, okay, because the patient was in shock. So the reason for showing this CT scan was, to show you the spectrum of trauma patient, with grade 4 and grade 5 liver injury, with a contrast blush, and giving you concept of contrast blush, hyper-enhancing adrenals, hyper-enhancing bowel wall, and a striated nephrogram because of tubular necrosis. So this was all due to, patient being in shock, losing a lot of blood, and this was kind of shock ball kind of picture, okay? Case number 9, this was actually a female who again came from Afghanistan, and she came with the history of headache, and this was actually in the pre-COVID times, okay? And we did her MRI brain. Initially, this was reported as glioblastoma. And before going to the MDT and for having discussion with my neuroradiologist, who is, very good at his work, he just told me that, Palwasha, can you see that there are multiple T2 hypo-enhancing areas which are there in bilateral frontal lobes, giving ring enhancement. There's loads of edema. And on sagittal, we could see that this area of enhancement was also there in the ethmoid sinuses and going to the frontal lobes. So this was actually a case of, a fungal infection going from sinuses to the brain and causing cerebral abscesses with ring enhancement. So this was also, the patient also underwent biopsy, and this proved to be aspergillosis. This was actually just to show you, the T2 hyperintensity, okay? So a key to diagnose a fungal infection is to look at T2 hyperintensity and then look at subsequent contrast enhanced images, which would show you enhancement. This is, a universal rule if you are dealing with fungal infection in the sinuses, in the brain, or anywhere, okay? So it will give you T2 hyperintensity, and post-quant enhancement should give you, make you suspicious about fungal infection, okay? Case number 10 is 38 years old who came with headache, and a plain CT scan showed a hypodense area sitting in the cardiac subcortical white matter, and this was a T2 weighted imaging which showed a lesion, a signal abnormality, which was there in the frontal region, in the peripheral sign location, and this was non-enhancing, so we gave a diagnosis of glioma, okay? So the thing which I wanted to show you about glioma was this T2 hyper to intermediate dirty kind of signals in a glioma, okay? So always look at T2, okay? This will give you T2 dirty kind of signals, okay? Of course, if you're confused if this is a glioma or anything else, you would go for MRS. But, most of us would be sitting at places where we are dealing with 0.3 Tesla MRI, and, thinking about MRS would be impossible in that particular case. So then you should look at T280 sequences and look at these dirty signals, to make you think about a glioma. So this was, non-enhancing glioma. So why am I showing you glioma? Many of you have seen gliomas and you guys are, familiar with it. But, the fact I want to show you glioma is that the biopsy of this lesion was done, and it turned out to be a diffuse glioma, WHO grade 2. What I want to stress upon is the IDH mutant and 1p19q4 deletion, okay? Because these two terminologies are, talked about nowadays when you're talking about gliomas, okay? Even if you go to Radiopedia, you go to WHO classification of the CNS tumors, specifically the gliomas, these two terminologies is, something that they are talking about, and being a radiologist, you should know about these two things, okay? So it is actually, how they are gonna classify gliomas, okay? According to WHO, the 2016 classification, they have introduced these concepts of IDH mutant and one P19Q code deletion. Okay, so I just want to tell you what is IDH. IDH itself, it would just give you an idea if there is a genetic mutation or not, if there's a genetic mutation in the glioma cells or not. Okay, and one P19Q code deletion is something that is basically used to further classify the glioma if it is oligodendroglioma or not. Okay, so let's say glioma is a white term. Okay, but the fact that you should know about glioma is because these are very common tumors. In fact, these are the most common tumors of the brain, primary tumors of the brain. So you should be knowing about glioma, because if you sit in an MDT and your neuro colleague is talking about glioma and IDH status, and you are not familiar with it, and you are just looking here and there, they're gonna notice that, and they're gonna say that they're not familiar. The radiologist is not familiar, okay? Because you have to be on the same page as your colleague, okay? So glioma is a white term, okay? This would include astrocytomas, this would include oligodendrogliomas, this would include oligoastrocytomas, okay? But this would not include polycystic astrocytomas, this would not include gangliogliomas, neuromorphic xanthoastrocytomas. Those are separate, okay? Those we would define radiologically as separate entities because of their specific imaging appearance or enhancement. So when it comes to glioma, you are basically dealing with oligodendroglioma, astrocytoma, or oligoastrocytoma, okay? And then traditionally, when they used to, tell you what kind of tumor is there, they used to look at the type of the cells, okay? If it's an astrocytic cells, if it's an oligodendroglial cells, okay? And then they used to look at the grade of the tumor. But the WHO 2016 classification of these gliomas has introduced the concept of molecular markers and the grades, okay? Grade we already know it's from grade, 2, 3, 4, and then molecular markers is this IDH mutation that everybody is talking about these days. And very soon your FRCR examiners is also going to talk about it, okay? So let's say we are thinking and talking about astrocytoma. So astrocytomas could be IDH mutant or these could be wild type. But by definition, these should not have one P19Q code deletion, okay? And if it is IDH mutant, which basically means mutation is there, so it's going to respond good to treatment, okay? And IDH wild type is not going to respond good to treatment. It's going to be an aggressive tumor, okay? And let's say then we are talking about oligodendroglioma, and oligodendroglioma by definition would be IDH mutant, and it will have one P19Q code deletion. So this is the concept that you should know. Why? Because the WHO grade and the IDH mutation, as well as one P19Q code deletion, both of which have profound impact on prognosis. Let's say if a tumor has IDH mutation and one P19Q code deletion, you should have an idea that you are dealing with oligodendroglioma. And knowing these molecular markers, you can just tell or think that the patient is going to have a good prognosis because the tumor is going to respond well to treatment. And let's say you are dealing with grade 4 IDH wild type, which is a glioblastoma, it would have the worst prognosis, okay? So just go, I don't say go into much of the details, but just go so that you're familiar with these molecular markers, the newer classification, how we are going to say it's oligodendroglioma, how we are going to say it's an astrocytoma, okay? So next case number 11 was again, a patient who was having headache and presented with fits, non-contrast enhanced CT sagittal image showing an hyperdense lesion, and on MRI T2 flare post-con. This was hyperintense on T2, and this was sitting just in the left temporal region in cerebral cortex. And then this was in close proximity to the MC as well. On FLAIR, can you appreciate on FLAIR, this is not entirely hyperintense. Rather, it's hyperintense in the periphery, and the center is somewhat hyperintense, okay? And it is non-enhancing, okay? So this is actually a T2 FLAIR mismatch, okay? So T2 FLAIR mismatch, if you open Radiopedia, they say that, T2 FLAIR mismatch, of course, it's used for a glioma, but if you see a T2 FLAIR mismatch, as in this case, you can, tell your neuro colleague, or maybe in your report, you can say that I think we are dealing with an astrocytoma, and I think we are dealing with grade 2 astrocytoma, which is IDH mutant, because this is what T2 FLAIR sign tells you, okay? So previously this sign was previously used for protoplasmic astrocytoma, but that has been removed from the newer WHO classification of the glioma classification. And now this is used for astrocytoma, which is IDH mutant, which is grade 2. So you can always tell in your MDT, that it's T2 flare mismatch. I feel we are dealing with an astrocytoma, grade 2 IDH mutant, okay? And this is non-enhancing. So let me tell you, most of these gliomas, these would be non-enhancing. So one of my seniors, when I was doing my fellowship, he asked me, Palwasha, if you're gonna report a brain tumor, so what are the things that you're gonna report and what are the characteristics that you are gonna think about? So the first thing I told him, I said, oh, I'm gonna look at the contrast enhancement. And he said, Palwasha, if you're gonna see contrast enhancement, and then you are gonna think that you are dealing with the tumor, then you are doing a wrong thing, because most of the CNS tumors are gliomas. Most of these are grade 2 and grade 3, and these would not be showing contrast enhancement. Mostly these would not be showing contrast enhancement. Okay? So let not the absence of contrast enhancement make you think that you're not dealing with the tumor. Okay? And the reason why these gliomas are not showing you any contrast enhancement, because for a tumor, an intraparenchymal intraaxial tumor, to show you contrast enhancement, it should damage the blood-brain barrier. So gliomas are not damaging the blood-brain barriers. These grade 2 gliomas, okay? These are not damaging the blood-brain barrier. And the glial cells are usually mixed with the normal parenchymal cells of the brain. So there's no damage to the BBB and there's no enhancement, but there is a tumor, okay? That is sitting in the brain of this patient. So again, I would show you the biopsy of this patient. Radiological diagnosis, we gave low-grade intraaxial glial cell tumor. The HP came as diffuse glioma, WHO grade 2, IDH mutant, 1p19q non-co-deleted, which basically means non-co-deleted means that you are dealing with a glioma or an astrocytoma and not with an oligodendroglioma, okay? Again, third case, again glioma. I just wanted to show you, these gliomas because these are most common tumors. These are non-enhancing. These are giving T2 dirty signals. And, most of us, would think, is this a T2 edema? No, this is not T2 edema, okay? This hole is a tumor, okay? Which is sitting in the cortex, which is sitting in the wide mirror. This is in the peripheral sign, frontal region. Again, you can just see this is sort of giving T2 flare mismatch, okay? And not showing any contrast enhancement, okay? So this was again a glioma. And, this was the same patient who underwent surgery. And the reason I wanted to show you the scan was that, of course, we can see post-surgical changes. The neurosurgeon did a great job. This was post-surgical cavity filled with fluid, some aegis and meningeal enhancement. And this was, initially wrongly reported as the post-surgical edema. So the key to, to diagnose a post-op MRI is to see the pre-op imaging, okay? Always make that a habit, to see pre-op imaging, to see the characteristics of the tumor prior to the surgery, okay? Where it is going, what kind of signals are there. So this was, misinterpreted as edema, considering the fact that this was non-enhancing. But initially, if you see, the tumor itself was also non-enhancing, and this was quite large, and this was quite extensive, coming quite posteriorly, okay? So this was actually a small amount of the residual tumor. So make a habit of seeing pre-surgical imaging when you are reporting a post-op scan, okay? And always, I just want to concentrate on these T2 dirty signals from glioma, which most of us are misinterpreting as the associated edema, which actually is not the edema, okay? And again, the biopsy of this patient showed a low-grade glioma, again IDH mutant. Good news for the patient, okay? IDH mutant is gonna respond good to treatment. Deletion of 1p19q is not detected, which basically means that you're not dealing with oligodendroglioma. You are dealing with a glioma or an astrocytoma, okay? Case number 13, this was a patient who came from some other hospital after, surgery for his tumor, and pre-op images were not available. This was again wrongly reported Let me tell you the sequences. This is T1, post-con T1, flare, and T2. Okay. So how was this reported? This was reported, right-sided craniotomy defect, and there is post-surgical hematoma. There is no enhancement in the surrounding signal abnormality area. The signal abnormality area was reported as T2 and flare hyperintense, suggesting edema. Okay, so this is absolutely wrong. I keep on saying, look at T2 signals, okay? T2, dirty signals. This whole is a glioma. So maybe the neurosurgeon went with the purpose of maybe doing biopsy or debulking, I do not know. But this was just this much amount of tumor was resected, okay? And this whole was left, okay? So this is not edema, okay? Even if it is not enhancing, this is not edema. And just think, what kind of edema? Usually we study that, there's vasogenic edema with tumors, okay? And vasogenic is when it is sitting in the white matter in a filiform distribution. So what kind of edema is this that is there with the tumor and still moving cortex and the white matter? So this whole was a glioma, T2 dirty signals, and this was a post-surgical hematoma in the surgical bed. So this was incomplete resection of the tumor, and this was also diffuse astrocytoma grade 2 IDH mutant, okay? So IDH mutant, I'm again stressing, giving you the histopathology report as well. So summary about gliomas. Please go through IDH and 1p19q quotation, okay? Glioblastomas are no longer multiform, okay? As per 5th edition of WHO classification, glioblastomas, by definition, will be just IDH wild type. Full stop, end of story. That's going to be the definition of glioblastoma, okay? And contrast enhancement will not correlate well with the development, okay? Just remember that, okay? Sometimes, let's say, you have got a glioma, which is not enhancing, okay? But sometimes if you do a biopsy of that glioma, it might turn out to be, IDH wild type, okay? So contrast enhancement would not correlate with grade of malignancy, but perfusion imaging will, okay? So this is another point that you should remember. And always tell your neuro colleagues, okay? Let's say these gliomas, I told you already that these are actually mixed with normal brain cells, okay? So let's say a neuro colleague tells you, can you measure the size of this glioma, okay? You would say, let's say 5 into 5 centimeters, okay? But tell him that these gliomas, these are notorious for infiltrating the adjacent brain parenchyma without causing any signal abnormality in the adjacent brain parenchyma. So what I'm telling you is the signal abnormality which I'm seeing on an MRI, but in actual, the tumor is going to be larger than this. So the neuro people would be resecting a larger area of the tumor, of course, to get, clear resection margins, but also because of the fact that these gliomas are notorious for infiltrating into adjacent brain parenchyma. So tumor cells can be well beyond the margins of enhancement or signal abnormality. And actually, the tumor size is larger than what is seen on an MRI. Okay, so these are just clinical points. Okay, that can just help you in your clinical discussion or MDT maybe. Case number 14. Sabahat, am I going fine? Am I going slow?
No, you are perfect. It's fine. Thank you.
I'm not getting any, any feedback, so I just feel I'm talking to myself.
Well, it's not live.
Yeah, I know.
The chat is open for people, but we are just keeping quiet because you are going. But okay, now you can see the chat.
Okay, just let me see this chat. Oh, what's going on?
Everybody's quiet. But
okay.
Now they're saying, go ahead.
Okay.
You're going perfect. Awesome. Okay.
So this was a case number 14, a little time to go, so a little more patience is required.
No worries.
This was a young patient, okay, around 5 to 6 years old, and she came with a lump in her parotid region. MRI was done. This is post-con and pre-con T1 weighted sequences. And we can see there is a large mass which is enhancing and it is sitting there in the parotid gland. But we can also see that it's going medially and anteriorly into the masticator space or infratemporal fossa involving the pterygoids. And it is also abutting the masseter. Okay, so So whenever I show my residents this case, one of my residents, she said, okay, this is a tumor sitting in the parotid, and she was thinking about differentials of the parotid gland tumor, okay, which is not wrong, of course, she has to. But sometimes, just think about the demographics of the patient, okay? Let's say I said she's 5 to 6 years old patient, okay? And if you feel this is malignant, which it seems to be malignant and infiltrating the adjacent muscles, then the key to think or to activate your thought process is also to think about, the demographics. And if this is a pediatric age group and I'm dealing with a head and neck tumor, one of the things that should come into my mind is the rhabdomyosarcoma, okay? Because we know it's very common in the head and neck region of pediatric age group, okay? And this should be the thought that should come into your mind. So sometimes don't just look at the location of the tumor, but look at the demographics. So this was a proven rhabdomyosarcoma, okay? So which was sitting in the parotid. So don't just think about, the parotid tumors, because parotid tumors are not very common in kids. Then think about head and neck tumor, pediatric age group, rhabdomyosarcoma, okay? Case number 15, MRI orbits, T2, post-quant T1, a DWI, okay? So this patient came with proptosis and white pupillary reflux, and there was some enlargement of the right-sided globe, T2 hypointense mass that was filling the vitreous chamber, then T2 hypointense mass, which was filling the left-sided vitreous chamber, and the left-sided one showed, avid, slightly heterogeneous contrast enhancement, but right-sided one did not show any enhancement. On DWI, there was some high signals of bilaterally, which were hypo on ADC. So this was giving diffusion restriction. So, this was actually retinoblastoma. So the text would tell you retino as avidly enhancing, heterogeneously enhancing, etc., etc. But we have never seen, or maybe I've never, on my Radiopedia websites, I've never read a retinoblastoma, which is non-enhancing, okay? So we thought of it and we thought maybe it has grown so swiftly that it has lost its blood supply. And that is the reason maybe it's not showing a contrast enhancement, okay? So in this particular case, this was, a typical case, but non-enhancement was making us, confused, but then use your common sense, look at other sequences. So this was retinoblastoma, which has lost its blood supply because of the swift growth, and this was non-enhancing, okay? So in your exam, in retinoblastoma, you have to use typical buzzwords: transcleral spread, perineural spread, trilateral, quadrilateral retinoblastoma, look for leptomeningeal metastasis, and DWI is a great sequence when it comes to retino, okay? If a patient is post-chemo, post-treatment, laser treatment, whatever, okay? DWI is a great sequence. If you see if the tumor has shrunken, if it is even non-enhancing, but if it is giving you diffusion restriction, there is retinoblastoma residual, which is sitting there in the globe, okay? So, and the modality of choice, of course, is MRI. Don't go for CT scan because that has got, that is more crude when it comes to transcleral or perineural spread, and for the fact that it has got radiation, and these little kids are prone to developing secondary sarcomas. It's better to avoid radiation to these patients. So this was imaging spectrum of retinoblastoma and MRI pictorial view, which I wrote. Maybe I just shared it if anyone wants to go through it. These are just images: small retinos, large retinos, bilateral, unilateral, with retinal attachment, etc., etc. So in case you want to go through it. Case number 16, let's say I don't give you a history. Let's say this is an exam form and I say history is withheld. I just tell you this is 3 years old, male patient. So this these MRI images, these are T2 and post-quant T1. These are actually self-explanatory, okay? There's a prosthesis on the right side, okay? So common sense is, why would a child have a prosthesis? Maybe for enucleation. And why would there be an enucleation in a child? Because there could be retinoblastoma, okay? So just say, there is a prosthesis, then once you're thinking about retino, say that the contralateral globe is fine, but unfortunate patient had leptomeningeal enhancement and there was leptomeningeal spread of retino. So even if history is withheld, this is typical exam case and you are supposed to pick it up, say the buzzwords, say trilateral, quadrilateral, comment on the contralateral probe, okay? And then you can go ahead, okay? Case number 17, 24 years old female, breast lump biopsy done, which turned out to be invasive memory CA. Memo was done. Now, always remember, we have a concept that we are not going to do a mammogram in young patients, but once the patient is a biopsy-proven malignancy, then you can go ahead with memo, okay? Then you don't have to look at the age of the patient, okay? So memo was done. So there was a large mass with spiculated margins in the central breast, upper quadrant, and then there was a small satellite sitting with it, okay, in the axillary tail. So we couldn't see anything else, okay? However, the breast parenchyma was slightly glandular, but we did not see anything else, okay, on mammogram or sonomammogram, okay? And then the surgeon, thought of it that she's just 24 years old and the mass itself is at 11 o'clock position and the satellite was also there at 10 o'clock position. So they thought of breast conservation surgery. And they said, let's do a neoadjuvant treatment, reduce the size of the lesion and do a lumpectomy, okay? And not remove the breast, okay? So these were the MRI compatible clips which were placed in the satellite as well as the main mass. And because she was of the young age, because we thought that the breasts are dense and one of the indication for MRI breast is young age, okay? So MRI was performed. Now, what I wanted to show you was, this was post-contrast image, this is a large mass with nipple retraction, okay? And this is T2 fat suppressed, T1 fat suppressed, post-con T1 weighted sequences, and MRI proved to be quite beneficial in this patient, okay? Why? Because we can see so many multiple lesions which are showing contrast enhancement. These are showing spiculated margins, okay? So initially we just saw a large mass with a satellite, but now we see so many lesions. So then comes the concept of multifocality and the multicentricity, okay? So multifocality in a breast lesion would be if you see masses, okay, in the same quadrant, multiple masses in the same quadrant, or let's say they're satellite in the same quadrant. In that particular case, the surgeon would still think about, doing a lumpectomy, quadrantectomy, and breast conservation surgery. But when it comes to the concept of multicentricity, as in this patient, you have got so many lesions, malignant, which are in different quadrants. So there's no way the surgeon is going to think about breast conservation. He's going to straight away, think about mastectomy, okay? So that is the beauty of MRI to altogether change the management of the patient. I'm not very good at MRI breast, but little bit that I report with the help of my breast imaging colleague, I can just tell you that whenever you're reporting MRI breast, in your report, always think, comment on the parenchyma of the breast. That should be the first thing you are doing, and then start explaining the lesions in right breast, then left breast, of course, the axillary lymph nodes. And important thing is, even if you are reporting a CT scan or an MRI in a breast CA patient, always comment on the internal memory nodes. These are the internal memory vessels. Then you have to comment on internal memory nodes. One of my consultants once asked me, Palwasha, what's the criteria if you would say the internal memory nodes are enlarged? I didn't know. And she told me, Palwasha, if you get to see these nodes, even if they are 3 millimeters, this means they are enlarged. So usually you don't see them. If you get to see them, this means these are enlarged. So when you are reporting a breast mass on CT or MRI, comment on the internal memory nodes. Then after all, you just have to comment on sternum as well for osseous metastasis. And you can see that on T1, you can see small amount of lungs, even the liver. So comment on all those things, okay, when you are commenting on MRI breast, okay? Case number 18, 36 years old female was slightly raised CA125 levels. CT scan was performed. There were multiple peripherally enhancing lesions, cystic lesions, bilateral ectonexa with some fat strandings. She went an MRI, underwent an MRI, and this was T2, T1, post-con T1, DWI, ADC, and coronal T2. So on T2, we could see T2 high to intermediate signal lobulated, tubular structures in bilateral adnexa. And on post-con, these were showing incomplete septa, which were enhancing. On DWI, showed diffusion restriction. And so this was concluded as tubo-ovarian abscesses, okay? So again, why am I showing you this case? Because of the fact that every time when we get to hear about CA125 levels, the only thing that comes into our mind is, CA ovaries. And we are so much alert to see the ovaries, okay? But let me tell you that, look at levels of CA125. These are mildly raised, or if these are excessively raised, and then have a concept that CA125 levels are raised in surface epithelial tumors of the ovary, okay? Just like we discussed the germ cell tumor, dysgerminoma, it won't be increased in that. That could be malignant, but it won't be increased in that. So CA125 levels would be raised in surface epithelial tumors, first thing, okay? It's not very sensitive, okay? Let's say 50% of patients with ovarian malignancy would show raised CA125 levels just in 50% patients. So 50% of the patients, early ovarian tumor patients, will show raised CA125 levels, which means 50% would not show raised CA125 levels. 20% of the ovarian malignancy will not show raised CA125 levels. It will show you normal CA125 levels. Then mucinous tumors of the ovary, though belonging to the surface tumors, would not show you increased CA125 levels. And consider the fact that CA125 levels can be raised in benign entities, okay? So let's say like a fibroid or an endometrioma or peritoneal tuberculosis, okay? So theoretically, CA125 basically means ovarian CA, but when you become more clinically oriented, then you have to ask, how much is it raised? What's going on with ovaries? Is it benign or malignant? Is there something else going on? Okay, so that was just, to give you concept of slightly raised CA125 levels, and what was sitting in the ovaries was tubo-ovarian abscess. Case number 19 is 35 years old male, MRI spine, lumbar spine, T2, T1, post-con T1, okay? So of course, this is, a typical imaging of mexopapillary ependymoma, okay? This is causing buckling of the vertebra. This is expansal, this is intradural, extramedullary, showing contrast enhancement. However, in this particular case, I do not see a hemosiderin cap. But these ependymomas, we are always in exam. We are always telling, if we see a medulloblastoma, the next thing we are going to advise neurexis, imaging of the entire neurexis because of the drop metastasis. Ependymoma, okay, in the brain, okay, let's think you are dealing with an ependymoma, even that will cause drop metastasis, okay? Though not as common as medullo, but it will cause drop metastasis, okay? First, think about that concept. And the second thing, ependymoma, which is sitting over here in the conus, okay? This is very notorious for causing hemorrhage. So let's say if you come across a subarachnoid hemorrhage in the brain, and you cannot find a cause for it, the patient has been aggressively investigated. One of the possibilities that should come into your mind is a spinal ependymoma, which is sitting lower down, but being notorious for hemorrhage, can cause subarachnoid hemorrhage, okay? And in this, ideally, you should also go for imaging of the entire spine, because this could be, this could show you multiplicality, okay? This could show CSF dissemination, and this could show you multiplicality, okay? So from exam point of view, we are always memorizing medulloblastoma, drop metastasis, pineoblastoma, drop metastasis, etc., but we are never considering the fact that ependymoma, CSF seedling, multiplicality, okay? So keep that also in mind when you are in your exam or maybe in your clinical practice. Last case, good news for everybody. This is again a typical lesion, slightly atypical imaging findings. This was a patient who maybe, I don't know his symptoms, but he underwent a CT scan. CT scan showed a fluid attenuation area with some specks of calcification. Or here again, you can see some specks of calcification. There was no enhancement sitting in the posterior segment right hepatic lobe. This was, of course, imaging findings quite, suggestive of hepatic hydatid. But, when I was reporting this case and I was just looking at these small, these hyperdense foci, which was there in the lesion. And when I took the density, these were fat. And these fat globules were confusing me a lot. And that was again and again making me think if I should label it hydatid, if I should not. So then I searched up the text, and the text said, the fat density in the hepatic hydatid cyst is a rare finding. If a fat fluid level is noted in the hepatic hydatid cyst, it favors the presence of biliary communication. Okay. However, if small fat globules are noted within the cyst along with the presence of the cyst wall calcification, okay, just as in our case, it would favor cyst degeneration than a biliocystic communication. So a typical lesion with slightly atypical finding because it had fat globules. I didn't know hydatid can show fat because of the cyst generation. So this was something new and I wanted to share with you guys. So with this, we come to the last case. And so to the end of the session, thank you very much.
Thank you so much, Dr. Palwasha. These were excellent, amazing cases and a lot of important inputs from the clinical and examination point of view. So a bundle of thanks. The chat is open, guys. If I think if you have any queries or any comments. Dr. Palwasha, can you open your chat or should I go
No,
ahead?
I can't really, Sabahat, I can't.
Okay. One question is how to differentiate inguinal-scrotal liposarcoma from retroperitoneal liposarcoma and which one has dismal diagnosis?
Just see the epicenter of the tumor, okay? So retroperitoneal is clear-cut retroperitoneal, okay? Elevating the kidneys. Okay, that is the key for you to diagnose a retroperitoneal lesion. So all the retroperitoneal structures would be elevated if you're dealing with the retroperitoneal liposarcoma. And for it to be so large to go to the inguinal region, definitely it would be, causing a lot of trouble to the retroperitoneal structures. So just see the epicenter of the lesion. And as far as the morbidity is concerned, the large retroperitoneal liposarcoma going to the inguinal region would be associated with more post-surgical morbidity, mortality, as compared to just the inguinal-scrotal liposarcoma.
Okay, thank you. The next question is, what was the cause of fat in the hydatid cyst?
I just showed you, see, there was a degeneration. It said if the hepatic hydatid cyst is undergoing degeneration, it can show you the fat globules, okay? So it was not because of the communication to the biliary channels, because in that particular case, it would show you a fat fluid level. There was no fat fluid level. There was no biliary communication. There were just a few tiny fat globules, and they said that it could be because of the degeneration which is going on within the hydatid cyst.
Right. The question is, I think by MG, she means managing. Is MG teratoma a differential diagnosis in the case of inguinal liposarcoma?
Can be, but see, I think you are saying mixed germ cell teratoma.
Exactly.
Yeah, MG
True.
teratoma. So
Yeah.
mixed germ cell teratoma. Yes, can be. You can give, but when you look at retroperitoneal liposarcoma, so much amount of fat and soft tissue, the first thing I think should come as liposarcoma. Yes, in the differential, you can give MG teratoma as well, but I think you just have to. I think you have to look at the age distribution. Now, I don't remember the MG teratoma very well. Its demographics or its distribution, but if it is showing so much of the macroscopic fat, yes, you can give it in the differential.
Okay, let me stop